thank Leslie Newborn and Silver Cross Hospital for organizing this presentation tonight. I'd like to thank you all for coming with the inclement weather. This morning when I left for work at 6 o'clock in the morning, the street I live on, there was a big tree fallen on the street. I had to go into the garden to come across that. The road was blocked. We had to call someone to help. So we had some bad weather and you guys made it, so we appreciate it. Taylor and I have been working together treating patients with acid reflux, Barrett's esophagus, pancreas and biliary disease for about 4 years. And I am really proud to say that with the help of Silver Cross Hospital, we have been able to build a high quality, big volume practice that I think we have higher volume than most of the university hospitals in the state of Illinois. So acid reflux and heartburn are very, very common symptoms. So move this down a little. About 20% of adult population suffer from heartburn and reflux disease, and some of these people, significant minority of these people, are at risk of developing a condition called Barrett's esophagus that can go on to carcinoma of esophagus, a very lethal type of cancer. So I will start with a patient that I treated years ago. This was a 56-year-old lady referred to me with heartburn type symptoms for 10 years. So she was taking over-the-counter medication, later started taking Prilosec or omeprazole once a day, and her symptoms were under control. Recently, prior to referral to me, she had an endoscopy by one of the gastroenterologists that work with me, and they found a small nodule in lower esophagus. They biopsied the nodule, and it showed intramucosal carcinoma, or early cancer of the esophagus. Patient was sent to a surgeon and sent to me to consider either surgery or endoscopic treatment. Endoscopic treatment is called mucosectomy, where I go in and cut out this area. Very specialized, very few areas have that treatment available, very few endoscopists perform that. It's a little bit risky treatment. The surgical treatment consists of esophagectomy, where the surgeon goes in, takes out half the esophagus, pulls up the stomach into the chest. So, great cure, but it's a very morbid operation, takes 8 to 10 hours to do the surgery. Patient is in the hospital for a few weeks and then recovering at home for 12 to 16 weeks. And there's about 30% complication rate. So this patient opted for endoscopic therapy, and here is the patient. I'm performing an endoscopy. You can see the nodule right here. I have a special cap device that comes from Japan, attached to the end of the scope, and I suction the tumor into this cap. Then the base of the tumor and normal mucosa, normal lining around it, I grasp with the snare and move it to and fro to make sure that I don't have the full thickness of esophagus, just the tumor and the superficial wall there. And then we cut it off using electrocautery, like so. And here you can see underneath there is normal looking muscle layer, the deeper wall of esophagus. So this is a perfect outcome that we want in our patients. Then we can suction out the piece of tissue that had the intramucosal carcinoma. So here I'm suctioning the tumor into the cap, and then I brought it out, sent it to pathology. At pathology, this revealed intramucosal cancer. The margin, resection margins were clear, about 1.5, 1.4 millimeter in each area from the tumor. So this patient was basically had a pathologic cure. We followed her with endoscopies every 3 months for 2 years, every 6 months for 2 years, and then yearly. And at 5 years, she had no recurrence. So she was basically cured of her tumor. And this was done in, I can't see the date very well, but it was either 2005 or somewhere around that time. And she's doing well. So, with that much, that case as a background, serving as a background, this patient had lifelong reflux, developed Barrett's esophagus, went on to develop early cancer, and fortunately was caught at an early stage, so cured with endoscopic treatment. slightly more advanced, and she would have required surgery or would be uncurable. So what is gastroesophageal reflux disease? At a simple level, it is the inability of lower esophageal sphincter, this is a normal sphincter in human beings between the stomach and the esophagus, to prevent reflux of stomach contents into the esophagus. Here is a diagram. To the left is a normal esophagus. This would be the esophagus. This thing is the diaphragm here, and here's the stomach. This is a normal esophagus and stomach, the junction here. This area here, which is like a pinch crop, closed up here, is called lower esophageal sphincter. This is the most important organ to us. It's the muscle sphincter when it comes to treatment of gastroesophageal reflux disease. In many people with age, obesity, other reasons, this sphincter becomes relaxed. The stomach also wall becomes a little relaxed, and you get this type of angle. And here you can well imagine that every time the pressure in the tummy rises, whether a patient coughs or bends forward, stoops, or for any reason, there will be reflux of these contents from the stomach into the esophagus. There's nothing stopping the reflux now, except gravity. If the patient goes to lie flat, again, you'll have free flowing reflux. So heartburn, which is a common symptom, many of my patients confuse it with reflux disease. Heartburn is the symptom. Underlying problem is the reflux disease. So heartburn is the smoke, and reflux, gastroesophageal reflux disease is the actual condition of fire. What are the symptoms of gastroesophageal reflux disease? Chronic heartburn, discomfort in the chest, lower part of the chest, is the commonest symptom, but not the only symptom. Many patients have trouble sleeping because when they lie flat, they have all sorts of symptoms, including food regurgitation, acid taste in mouth, coughing, aspiration, gas bloating, limitation of certain foods like pizza or any fatty meals, coughing, and sore throats. Those are some of the other symptoms of gastroesophageal reflux disease. As I mentioned in the beginning, reflux disease is very common. About 1 in 2 Americans develop gastroesophageal reflux disease at least once a month. But that's not what we call reflux disease. That's basically almost a normal phenomenon. Anyone who overindulges in food, alcohol, smoking, etc., can get reflux sometimes. That's considered normal. However, if you get heartburn and reflux symptoms once a week or more often on a regular basis, that's when we call it gastroesophageal reflux disease, and that's when you need to see a doctor. About 1 in 5 Americans, or more than 50 million, close to 50 million Americans suffer from gastroesophageal reflux disease. And it's a costly business, costs a lot to American employer, average cost being $3,000 per employee annually, because of the sick days, chest infections, cough, colds, and other issues. One of the complications of reflux disease is Barrett's esophagus. About 3.3 million Americans, adult Americans, have Barrett's esophagus, or the estimates by NIH. So I'm going to talk first about gastroesophageal reflux disease, a little more detail, and then talk about Barrett's esophagus and the treatment options that we have currently available. As I mentioned already, reflux disease is due to the laxity of lower esophageal sphincter. In a normal person, the sphincter mechanism is preserved. There is an angle here called angle of Flace, where if the stomach pressure rises, this angle pushes and closes this valve completely. But in patients with reflux disease, there's almost no valve. So there's reflux every time the intra-abdominal pressure rises above the thoracic pressure, or every time they lie flat, they can be reflux. Causes of reflux disease include obesity, diet, age, smoking, and certain medication. Diet, as we know, we have a supersized culture here. These things are hopefully changing but somebody called it weapons of mass destruction. I think the supersized meals from McDonald's and other chains have really a big part to play. We did not see this much reflux in the 60s, 70s, and early 80s, but late 80s, 90s, and onwards is an epidemic of obesity, epidemic of reflux disease, and with it, rising incidence of carcinoma esophagus. And I'll come back to that later. So the treatment of reflux disease includes lifestyle changes, medication or pills, surgery. We can watch and wait with these and hope for the best. So lifestyle changes include limiting the trigger foods. What are the trigger foods? Mostly fatty meals, meals with high fat or high carbohydrate, very sweet meals or fatty meals. In addition, alcohol, smoking, and certain medication. So pizza, for example, especially the thick Chicago pizza, is a bad one for reflux. Anything that are fries or contain extra fat content would cause reflux by reducing the lower esophageal sphincter pressure. And then meals that are high in carbohydrate content, especially chocolates, desserts, etc., would again cause reflux, make you more prone to reflux disease. They suggest that you should eat slowly. That is a good habit anyhow, but eating slowly helps prevent reflux as well. The food is more digested, sits in stomach for less time, the smaller pieces of food, and is emptied quicker. So with that, we have less tendency to reflux. Weight reduction helps. Obesity especially causes fat deposition in the abdominal organs and around the abdominal organs. It causes rise in intra-abdominal pressure. So I tell my patient typically if they're overweight, if there is a weight margin, if they can lose 20, 30 pounds, that would help a lot. Smoking cessation, alcohol, cutting back on alcohol would be a good idea. And then avoid eating at least 3 hours before going to bed. What happens is when we eat, the stomach has food and stomach produces a lot of acid. It's what we call maximal acid output occurs after eating when the stomach is full. And that acid tries to digest the food, stomach is contracting hard and raises the intragastric pressure as well. That makes you more prone to reflux if the valve is weak. It takes about 3 to 4 hours in an average person, typically 2 to 3 hours for stomach to empty completely. Once the stomach empties, it goes into a sleep mode. There's not much secretion of acid, the stomach pressure is gone, the contractions are gone, the active peristaltic rhythm. So then there's much less tendency to reflux. That's why we like our patients to eat at least 3 hours, maybe more, before going to bed, before lying flat. Medication or pills for reflux disease, antacids, H2 blockers, and proton pump inhibitors. These are the 3 class of drugs that we use now for reflux disease. About 10-15 years ago, there was a big buzzword called prokinetic agents. These were drugs that contract the esophagus and stomach, improve contractility, and help with stomach emptying and clearance of esophagus. Those drugs, unfortunately, there was only one main drug, cisopride or propulsate, has been pulled off the market. There was some reaction with drugs causing dangerous ventricular arrhythmias. The company didn't want to take any risk, so now it's only available on a compassionate basis. Great difficulty. So that drug is gone. It was a good drug, but unfortunately had a bad side effect. So now we are left with antacids, which is the weakest in the class, and then proton pump inhibitor, which is probably the best and gold standard at this time. And acid basically is alkali that you swallow, and it goes and tries to neutralize the acid. Unfortunately, the stomach can sense that, or stomach is smarter than that. So when the stomach pH rises, meaning stomach is becoming alkaline, the pH, the parietal cells in the stomach start secreting more acid. So every time you take an antacid, you have rebound acidity afterwards. Antacid will work for 10-20 minutes. Within an hour, acid will come back with a vengeance. H2 blockers include the drugs Zentec or ranitidine, Pepcid, and Tegamet, which was cimetidine, old drugs. These drugs revolutionized the treatment of acid reflux and peptic ulcer disease in 80s and 90s. Tegomet was the oldest first drug. The person who introduced Tegomet, who produced Tegomet, got a Nobel Prize. And that was the time when we were treating ulcer with surgery, taking out half the stomach. That surgery died out. There were surgeons who just did partial gastrectomies or cut out the stomach and attach half the stomach to the small bowel. Those surgeons started doing hernias and bowel because after these drugs came out, peptic ulcer surgery died as an option. Then came proton pump inhibitors. These drugs are the commonest drugs used in the market today. This includes Protonix, Prevacid, Nexium, and now Dexilant. These drugs have really revolutionized the management of gastroesophageal reflux disease and peptic ulcer disease. So any condition associated with acid secretion, these drugs are the best management currently, as far as drug treatment is concerned. Surgery is another option. Surgery, you go in and tighten the junction between esophagus and stomach. It is an effective operation, common and minimally invasive. There are some risks related to incision and surgery, including infection, recovery period, etc., but it's pretty effective. The main problem with surgery is typically the benefits last 3 to 5 years. After that, somehow the lower esophageal sphincter becomes loose again in many patients. About 70% of patients, or 2/3 of patients, in 5 years to 6 years time are back on proton pump inhibitor. The reflux comes back. For the last 7 years, we have what we call transendoscopic incisionless fundoplication, and I offer that procedure. It's available in very select centers in the state of Illinois. We provide this service. Basically, we go in with an endoscope and tighten the junction between esophagus and stomach, much like the surgeon, but using an endoscope. There is no incision involved. Here you see the device loaded on an endoscope, and we are suturing the junction between esophagus and stomach, creating a valve, just like the natural valve. So this one is effective, as effective as surgery in most cases. In patients who have larger hiatal hernia, this is not a good option. It's not an option actually, but otherwise very effective, and it is non-invasive, or at least less invasive than general surgery. Complications of gastroesophageal reflux disease include erosive esophagitis, where you get ulcers in the esophagus. When these erosions or ulcers heal, can form a stricture of narrowing of the esophagus, which causes difficulty with food going down. Patients get difficulty swallowing, can get deep ulcers, and this can go on to Barrett's esophagus and carcinoma of esophagus. Here is a picture of Barrett's esophagus. Normal esophagus mucosa looks like this. It's a salmon-colored mucosa or lining of the esophagus. In patients with Barrett's disease, the lining changes to more like the small bowel mucosa. We call it intestinal metaplasia of Barrett's esophagus because this lining changes due to chronic chemical stimulation, chemical irritation. So how does Barrett's esophagus develop? Due to gastroesophageal reflux disease, patients have chronic acid reflux. The normal lining of stomach is used to acid, is made to deal with acid, and there's no problem. But when the acid comes back into the esophagus, the esophageal lining is not unable to deal with acid environment and develops chemical irritation, inflammation, can go on to develop ulcers, and then eventually 5, 10, 15 years down the road, about 10% of patients develop a condition called Barrett's esophagus, which means the lining of esophagus changes to a different type of lining, much like small bowel. Here are the stages. A patient with a normal lower esophageal sphincter, normal junction, this side is esophagus, this would be the stomach side. And then patient who has reflux disease and erosions, long linear erosions in the esophagus, and when it heals, it has formed a condition called Barrett's esophagus here. In this patient, there is progression with these small nodules which are considered dysplasia. If you biopsy those, you find either early cancer or dysplasia. And then here is a carcinoma of esophagus, one of the most lethal cancers known to mankind. This is an important graph. It shows the incidence and prevalence of different types of cancer in the United States. This is taken from SEER database. SEER database tries to keep record of at least 10% to 15% of cancers occurring in the United States across the nation. And you can see between 1975 and year 2000, the incidence of colorectal cancer has stayed more or less the same, slightly less. Lung cancer about the same, so is the breast cancer. However, prostate cancer and melanoma is rising. And there's about 1.5 to 2-fold rise in the incidence of melanoma and prostate cancer. However, if you look at carcinoma esophagus, there's about 7-fold rise, 700% rise in the incidence of this cancer. And this is an extremely lethal malignancy. We think it's related to change in dietary habits of the nation, people becoming more overweight and more sedentary lifestyle, with more technology, cars, and those things available. The good news is that we can prevent cancer of esophagus if we treat it at an intermediate stage. When these patients with acid reflux develop Barrett's esophagus, we can treat it just like we treat colon polyps, just like we treat the precancerous nodules in the breast and skin lesions. So it is preventable. There are 3 treatment strategies currently available to patients who develop this complication of chronic reflux called Barrett's esophagus. It is endoscopic surveillance, endoscopic mucosal resection, the treatment that I showed you in the first video clip, and then endoscopic ablation therapy. Surveillance is basically simple. You perform endoscopies at recommended intervals. Look at Barrett's, do biopsies. It is considered standard of care. Most insurance companies reimburse these endoscopies. We perform an endoscopy within 8 weeks, and then at every 3-year intervals, the patient has no dysplasia, more frequently in patients with dysplasia. However, the problem is it does not remove Barrett's esophagus. It is really a wait and see policy. If Barrett progresses to cancer, then we intervene. So many patients are anxious about it and do not want to wait too long. Most of my patients, once they have Barrett's esophagus, they want to treat it rather than doing periodic endoscopies. It does require frequent endoscopic treatments as well, so that's associated with cost and other issues. If patient has plain Barrett's, the endoscopy is repeated after the first diagnosis within 8 to 12 weeks, and then every 3 years. If patient has dysplasia, it's categorized into 2 types. Low-grade dysplasia, where we repeat endoscopy every year, and high-grade dysplasia, where endoscopy is repeated every 3 months. And we perform biopsies every centimeter in this condition, 4 biopsies per quarter. So surveillance is controversial. As one of the famous Barrett's doctors said, Steve Sontag, is actually from Chicago, Heinz, the best day in life of Barrett's patient is the day his endoscopist dies. Because they require so many endoscopies that some patients used to get fed up of this. So this is the statement Dr. Sontag came up with jokingly. Endoscopic mucosal resection is what I showed you initially. It basically is a technique where we go in, cut out the Barrett's mucosa, leave the muscle layer behind, put the patient on pump inhibitor so there is no acid coming back or not much acid coming back. And when the thing heals, the wound heals, they get a normal esophageal mucosa. So you get rid of the precancerous epithelium. It has the advantage, it enables evaluation of diseased tissue. So you get pathology, you get a specimen that's sent to pathologists, they can tell you if there was high-grade dysplasia, cancer or not. very often reveals more advanced tumor state than the biopsy had shown previously, and it can be used to obtain large biopsies. The problem is that expertise is not widely available. As I mentioned, I'm one of the few endoscopists in the state of Illinois. The others are mostly in university centers who perform endoscopic mucosal resection. Malignancy and high-grade dysplasia, we can't always identify endoscopically, so we cannot target an area. We might have to do a wide resection. And to avoid recurrence, we'll have to treat large area of Barrett's by this technique and then perhaps burn the rest of Barrett's esophagus. Ablation is where we go in and burn Barrett's mucosa with a special device, and I'll show you images of those devices later. It's called radiofrequency ablation device or Barrett's procedure. The procedure is simple and widely available now. All hospitals that I go to have this technology available. Procedure is fast, takes about 20-24 minutes to perform. It's performed in an outpatient setting, and it treats the Barrett's epithelium by burning it. However, we don't get any pathology. There is no tissue available for pathology, which I think is the biggest limitation of this. So in patients where I'm suspecting high-grade dysplasia or intramucosal carcinoma, I do endoscopic resection rather than this treatment. There is some mild discomfort or soreness after the procedure. Some patients get severe pain. 1 in 10 patients get severe burning pain that can last up to a week. Typically 3 to 5 days, but can last up to a week. We recommend liquid or soft diet for a week afterwards, and may need more than 1 treatment session. Most patients require 2 to 3 treatment sessions to get rid of all the Barrett's. Factors influencing the intervention or treatment options include patient factors, which would be the age of the patient, comorbidity, patient's opinion, physician factors, expertise. Physician often needs to be trained in another technology called endoscopic ultrasound that I did not touch, but is often needed when patient has nodules. As my teacher used to say, a fool with a tool is still a fool. So you need an expert, a person who performs high volume of these advanced procedures to treat it appropriately and safely. And with patients and proper technology, expert physician, the cure rate in Barrett's esophagus, 98.4% of patients have no Barrett's at 5-year interval when treated with ablation technique. More than 90% with dysplasia have Barrett's, no evidence of Barrett's esophagus at 5-year interval once treated with radiofrequency ablation, and same with high-grade dysplasia. So the results are very good. Here is the technique. Basically, you look at the Barrett segment. This is the esophagus. The area above this, the whitish, pale-colored mucosa, is the normal mucosa. Below here is the Barrett's type of mucosa. So you measure it with your endoscope, 3, 5, 7 centimeters. How long is it? And then you bring this balloon-type device that provides the heat in the form of radiofrequency energy. You bring the balloon in the area, inflate the balloon, and apply the energy. You deflate the balloon, and you see a coagulum or burn like this, which is a superficial burn. Then you move the balloon down and do the same thing again to get rid of all the Barrett's type epithelium. When the patient comes back, usually there is some spot that are Barrett's left. Here you can see a small spot, and then you use a different device, which is like a spatula or cap that we put on the end of the scope and burn the area. So with these two modalities, we are able to treat Barrett successfully in almost every patient with no recurrence. About 98% are recurrence-free at 5 years with classic Barrett's, and 90% have no evidence of recurrent Barrett's at 5 years if they have dysplasia. Dysplasia is a little harder to get rid of. So very good results. And here you see a patient who had long segment Barrett's, and after treatment, that all that mucosa is gone. So I think I'll stop here and take any questions about acid reflux disease or Barrett's esophagus.